All right, good morning. We're going to talk crystals today. So we've already gone through the microscopic examination of our cells, our casts, and now we're going to talk on crystals. So we'll take a look at, just an overview. We'll look at the crystals that we commonly find in acidic and alkaline urines, and then some abnormal crystals that are metabolic in origin and iatrogenic in origin. So typically when we're going to look at crystals, we're not usually finding them in freshly voided urine. Typically we're going to see them develop after urine has stood for a little while. Usually they're not really significant. Sometimes they can indicate a predisposition or, kidney stones. So that's typical, your calcium oxalate, your uric acid. So most of our crystals are clinically insignificant. So typically our clinically significant crystals are present in freshly voided urine, not necessarily urine that are sitting around. So for class purposes, when we're getting donated urine, which is a challenge this semester, but if I donate urine or our lab instructor donates urine, we can see crystals form just for it sitting in the refrigerator waiting for your lab to begin the next day. So it doesn't necessarily imply that you have a kidney stone. It doesn't confirm any of that, but you could potentially see kidney stones in the future if you have a large amount of these crystals present. So we can see inherited metabolic disorders that can produce amino acid crystals like cysteine or leucine. And then we can see patients that have had high dose drugs and supplements to cause formation of crystals in their metabolites in the urine. So salicylates, sulfonamides, and vitamin C. Vitamin C is a common one because people think, if you take a ton of vitamin C, it's going to help boost your immune system. Well, yes, vitamin C does help boost your immune system, but when you take it in excess, you just urinate out the rest of it. So crystals will typically form and they'll come in urinary sediment in vitro as the urine cools to room temperature in whatever container it was collected into. They will precipitate out of solution when the concentration in the solution is greater than the solubility threshold for that solute. So the factors that affect crystal formation is the pH of the urine, the solute concentration in the urine, and the kidney filtration rate. So we will classify them as normal and abnormal, and we will classify them by the pH. So normal acidic crystals, normal alkaline crystals, and abnormal crystals. And again, these will be metabolic or iatrogenic in origin. So characteristics we're going to look at on crystals: the pH, the morphology, the polarization and bifringence, and the solubility. So the polarization will help in crystal identification, and we can use two polarizing filters that will darken the field. Crystals will polarize the light. That polarize the light will reverse the filter's effect. This is not something that we commonly or routinely do in the lab, simply because most of the crystals we can identify on site. So this is an example of a polarized light of a uric acid crystal, which is that typical lemon or football shaped. So bifringence, so a polarizing filter with the first order red compensator, it will demonstrate the crystal's ability to split light into the spectrum. So negative bifringent crystals will rotate left to the light to the left, not left to the light. And then positive bifringent crystals will rotate light to the right. So this is an example of the bifringence. It also makes really pretty colors and wall art. So we're going to look at crystal, and we'll talk more about polarization and bifringence when we start delving into body fluids. That's where we're going to use polarization and bifringence a little more commonly, because we're going to do that typically in synovial fluid when we're trying to see if the patient has gout or not. So the acidic crystals that we see, so uric acid, urates, and calcium oxalate. So we'll start, obviously, amorphous urates, and then work our way into the other crystals as well. So the amorphous urates themselves are essentially just, they look like dirt. And they typically are going to cause problems when you are trying to do your microscopics, because if there's a large amount of them after it's been standing for a little while, it can basically cloud your whole field, and it just looks like you're looking under a microscope that's full of dirt. So typically a little warming, if you put it into some warm water, it will help dissolve that. So when we look at uric acid, the pH is usually less than 6, and sometimes we can see amorphous urates, and they have distinct shapes when you see uric acid. So here's your typical lemon shape of your uric acid. The concentration will depend on our dietary intake of purines and the breakdown of nucleic acids. And we can see these in patients with leukemia that have chemo. And we can associate this potentially with gout when it's accompanied by increased serum uric acid. It is only considered pathologic when we see it in freshly voided urine, because remember, upon standing, these crystals are generally clinically insignificant because it just takes some time for them to form. So this is an example of uric acid. You can also see this kind of growing out in two planes. So this is one sheet that's this way and one sheet that's the opposite direction. You can see them all clumped up and together, but you can still kind of see that diamond or football shape. We can see sometimes in some clusters. So right here, this here looks almost like cylindrical, but then you can see the rest of your lemon shapes or football shapes. Sometimes we can see rhomboids, or this is a really good example of a barrel of uric acid as well. Sometimes they can clump up like this, so you can really only see the clumps. So you can see a lot of different ones. I recently got and I'll show it towards the end and see what you guys all think. I got a former student who works in a lab sent me a mystery patient. It was something that they really couldn't figure out what was wrong with the patient. They had very minimal data to work with, just one urinalysis and one serum, one blood draw, and the patient was already discharged. And she reached out to me just out of curiosity, because it's something that she had disagreed. So she'll typically do this. She had disagreed with the pathologist, and she kind of wanted to see what I had to think about it. So she'll typically give me no details and just ask me what it is. So this one was actually kind of a stumper, but I'm going to give it to you and see what you think, and then we can talk more about it after. But that'll come towards the end of the PowerPoint, because I got to pull up the slide. So here's your amorphous urates. So as you can see, again, I forget what order I'm in, and I talk ahead of the PowerPoint slides all the time. So these are typically, you can see it looks like dirt throughout the microscope. And if it's in large amounts, it can actually cover up cells and casts and things like that. So we have to be really careful. And it can show like when it's a sediment in the actual urine cup, it can have like a pinkish color to it, like pink beach sand. Sodium urates, we can see occasionally. They're colorless or sometimes have a yellow color. They're needles or slender prisms that sometimes you can see in clusters or sheaves. Not very common to see those, and we don't really care much about those. So uric acid does polarize the light, and when you view with that red compensation filter, it will demonstrate negative bifringence, so yellow when it's aligned with the filter. It'll dissolve in alkali, and it's insoluble in alcohol, HCl, and acetic acid. So here you go. Beautiful bifringence. There's that yellow. Very lovely. So calcium oxalate, the pH is usually acidic, but we can sometimes see it in neutral and alkaline urine. We will often see this when we have kidney stone or lithiasis. 75% of our kidney stones that we see in patients are composed of calcium oxalate. We can see increased calcium oxalate if there's a lot of rhubarb or spinach intake, or ethylene glycol poisoning, or your antifreeze poisoning. So these calcium oxalate look like little tiny envelopes. So your bipyramidal shape. So it's basically an X marks the spot in your little square. Sometimes we can see an oval shape, and it can look almost like a barbell on its side. So you have to be very careful when you look at those. It'll dissolve in sodium hydroxide, hydrochloric acid, and not in acetic acid. Then we can see Hipfiric acid. pH is usually acidic, but again, just like calcium oxalate, we can see it in neutral or alkaline urine. It's rarely seen in urine, and it's little to no clinically significant. So it kind of looks like this. And a lot of the times you will encounter this, and you may just kind of pass it off as a skippa artifact. You won't really see anything that looks like this other than the one crystal. So it's not really common, and we don't really care. It'll dissolve in hot water, sodium hydroxide, and it's not soluble in acetic acid. So then we move on to crystals that we commonly find in alkaline urine. So your phosphates, your carbonates, and your ammonium biorate. So again, triple phos is our most common one that we see. We can see ammonium biorate, but again, that's older urines. Excuse me, calcium phosphate, calcium carbonate, and then we can also see the amorphous phosphates, which are basically the sister to amorphous urates, except we find this one, the amorph, in alkaline urine. And often we just call it amorph. We don't distinguish phosphates or urates. So our phosphate crystals, so our amorphous phosphates in alkaline urine, triple phos or ammonium magnesium, also referred to as struvite. 10 to 20% of urinary calculi can be triple phos in nature. It has a nice distinct coffin shape, and then we can look at calcium phosphate. So our triple phosphate, your coffin lib or your prism shape. Sometimes you can see like broken up picture frame edges. So you can see this one's kind of like, if you put these together, you could form a picture frame. They polarize light. Isn't that beautiful? I actually have like a little piece of jewelry that kind of looks like that. That's kind of funny. Good wall art. It will demonstrate bifringent, and it will dissolve in acetic acid. This is one of my favorite crystals, just because I don't get to see them as often in the lab, and we don't actually have a polarizing filter in our lab. And although we did get new microscopes, so you never know. But they're fun. Ammonium biorate, these are seen again in alkaline urine. It's usually in old specimens, and it's only abnormal if we find them in freshly voided urine. They're thorny apple in shape. So basically, we can see this is the most common form where we see like the little spines or your thorny apple, yellow, dark brown color. Sometimes we can see this rare form that has no spicules and it's just like little round blobs. It will dissolve in acetic acid, sodium hydroxide, and when we heat it. So abnormal crystals of metabolic urine, in metabolic, sheesh, can tell which lecture I'm giving. Cysteine, tyrosine, leucine, and cholesterol are our abnormal crystals. So cysteine, we will find in acidic urine. The metabolic disorder that's associated with it is cystinuria. It's and again, we're going to talk more about these metabolic or inborn errors of metabolism. So it's an amino acid transport disorder that's inherited that specifically affects cysteine. We can see cysteine stones, kidney damage that can fill the renal collecting system, and we can see staghorn calculi that will cause renal stasis in these patients, among other things. But these are they're colorless hexagonal plates, very refractile. Sometimes you can see this being confused with uric acid, but when you see them in these perfect forms like this, they are not. Typically, we are seeing this not as commonly because we can diagnose this in childhood when we screen for inborn errors of metabolism, but sometimes we can miss it. So it will dissolve in hydrochloric acid, sodium hydroxide, ammonium hydroxide, and it's insoluble in acetic acid, alcohol, and ether. And we will do the acid test or your nitroprusside reaction to confirm the presence of them. Tyrosine, we will see in acidic urine or severe liver disease. These are rarely seen crystals, and they're colorless needles in bundles or sheaves. So this is not something we commonly see. It will polarize the light, it will dissolve in HCl and AOH, and when we heat it, and it's insoluble in acetic acid, alcohol, and ether. Leucine, we will see in high acidic pH. We will often indicate liver disease when we see them in conjunction with tyrosine crystals. So these basically kind of look like grapefruit sections or a half of a grapefruit. So they're yellow, oily looking spheres with striations and a thick outer border. Sometimes we can see these alongside of a tyrosine crystal, but again, not as common to see these as well. It will polarize the light into a Maltese cross, so it can do that as well. And then some of that outer edge can kind of look like crushed diamonds, so that makes it a little easier to identify. It'll dissolve in NaOH, and when heated, and it's insoluble in acetic acid, HCl, and ether. Cholesterol, we'll find these in acidic pH. The free fat formed from degradation of renal transitional epithelial cells. So these can be present in fatty acids or in cases of nephrotic syndrome. So these have this, irregular, like rectangular plate, and typically they have corners that are notched out. So you can see here a notched out corner. We can sometimes mistake them for radiologic dyes because radiologic dyes will have these little thin, like needles that are present as well. It will polarize the light. It'll dissolve in chloroform, ether, and hot alcohol, and it's not soluble in dilute acids or dilute alkali. Bilirubin crystals, we can often see bilirubin in crystals in acidic urine. We can see this present in bilirubinuria, and it has the same significance of bilirubinuria. They're reddish-brown needles or granules, and often the color of the urine is also very dark as well. They will dissolve in acetic acid, HCl, and AOH, acetone, chloroform, ether, and they're not soluble in alcohol. Some things that we can see that are iatrogenic, so we already talked about these, your drugs, supplements, and radiologic contrast media. So sulfonamide drugs are one that we can see in an acidic pH urine. This will indicate renal damage as these precipitate out into the nephron. So these are sulfonamides. They're yellow to brown needles and sheaves, but have a lot of different shapes. So I know they can be confused with tyrosine because tyrosine can sort of kind of look like this, but remember tyrosine are clear and they don't have this typical like tuft on each side. And you'll see a little more variety in shape. And they are very, very pretty when they polarize the light, and they demonstrate bifringence. They dissolve in acetic acid and AOH, and they are not soluble in dilute acetic acid, and we will do a lignin test to confirm the presence of sulfonamide crystals. Other things that we can see, so this one here, your ascorbic acid. This is a polarized ascorbic acid crystal. Very cool looking, right? We'll see them in acidic pH, and we'll see them in high doses. Contrast media, typically needles, rectangles, and some varieties, again, can look like cholesterol crystals, so you have to be careful. Renographin, hypake are the typical contrast media that we can see present. These do polarize the light, so they'll look like this. Other confusing things that we can see, starch, talc, and glass fragments. So these are starch, and they often will polarize the light to have that Maltese cross look. And they're usually uneven and very, very refractile, and they can have an indentation and very, very dark outline. So when in doubt, when you are identifying structures in the microscopic, if it's got that real black outline and it's not a crystal, it's most likely an artifact. So these are talc and glass fragments, so they kind of look similar, but very jagged edge, very dark on the outside as well. All right, so that is your crystals, and now I'm going to pause and I am going to give you the mystery crystal and your lecture test code. So your lecture test code for today will be 279. All right, so here is the mystery. So take a look. See what you think. I'm going to let you kind of look at it for a minute. So we see here, you can see these little structures here. I'll tell you what those are. Those are your white cells. And then we have a couple that look like little red blood cells. See these little guys back here? All this here? That's mucus. We have some epithelial cells, okay? Epithelial cells, this stuff's kind of out of focus, so we can't quite tell, but you can see mucus. But what are these guys? This one that looks kind of like an alien head. This one here, this here, this here. What are these? All right, so that's going to be your mystery. Tell me what you think they are, and that's going to be in your lecture test code as well. So you'll have 2 questions this time for that quiz. And then we'll have a kind of a discussion because this patient is a bit of a mystery because this patient was discharged. So all we have is this and some blood draw results, and that's it. No diagnosis, nothing. So enjoy. I'm really looking forward to see what you think.